Hello, my name is Dave Shahian. I'm the chair of the Council on Quality Research and Patient Safety for the Society of Thoracic Surgeons and past chair of the workforce on our national databases. I'm here today with three of my colleagues, Dr. Rich Prager, Dr. Jeff Jacobs, and Dr. Benj Kozower. The four of us are passionately engaged in the database activities and have been for a number of years. But we realize that not everybody in the STS is as familiar with the database as we are and may not appreciate some of the unique features of the database and why we are so positive about it and so enthusiastic about it. So we thought we would take a few minutes today to convey that information to you. So I'd like to have my colleagues introduce themselves and then we'll chat a bit about these features. So Rich, can I start with?
Sure. Rich Prager from Ann Arbor, Michigan. I'm past chair of the Council on Quality Research and Patient Safety and also had a role in the Adult Cardiac Surgery Database. And I will, in part of the discussion, talk about how we use the database in the state of Michigan and how we were enabled to engender support and enthusiasm to use it as a vital tool for quality improvement.
I'm Jeff Jacobs. I'm currently chair of the STS National Database Workforce. I was chair of the Society of Thoracic Surgeons Congenital Heart Surgery Database Task Force from 2006 until 2014. And after the introductions, I'm going to talk a little bit about the overall size and scope of the STS database and the role that the STS database plays in the national quality agenda.
Ben?
And I am Benjamin Kozower, a thoracic surgeon from Charlottesville, Virginia. And for the last 2 years, I've been the chair for the General Thoracic Surgery Database Task Force. And I'll talk a little bit about some of those things that are unique to thoracic, which has some significant differences compared to the congenital and the adult cardiac surgery databases.
Thanks, Benj. Well, Jeff, let me start with you. Is there anything that's particularly unique about the STS clinical database compared to other data sources that are out there? And remember that it's not just data collection that we're talking about, but what are some of the downstream things that we do with those data? In particular, you've been involved in the quality measurement area using data from the database. Tell us a little bit about that as well.
Well, the Society of Thoracic Surgeons National Database is the largest clinical registry in the world of patients who have undergone surgery for cardiothoracic disease. And the STS database has three components: the Adult Cardiac Surgery Database, the General Thoracic Surgery Database, and the Congenital Heart Surgery Database. One of the unique features of the STS database, and really all three component databases, is the penetration of the databases across the United States and the representativeness that those databases have for the domains of cardiac and thoracic surgery. If we start with the Adult Cardiac Surgery Database, we know that currently, as of today, over 90% of the adult cardiac surgical programs in the United States submit data to the STS Adult Cardiac Surgery Database. We've studied the relationship of the Adult Cardiac Surgery Database to the national penetrance of cardiac surgery using Medicare data to assess the denominator. And we know that between 90 and 95% of the programs that do heart surgery on adults submit data to our database. In the pediatric heart surgery database, we have a similar penetration of about 95% of all of the programs in the United States that do pediatric heart surgery. And although we're not completely certain what the penetration is of the General Thoracic Database, we do know that the General Thoracic Database is one of the largest, if not the largest, databases for patients undergoing all forms of general thoracic surgery, including lobectomy, pneumonectomy, and esophagectomy. With these large clinical databases, certain principles are important. One principle is, can we believe the data in the databases? And a unique feature of all STS databases is that 10% of the hospitals that submit data to the database every year undergo random audit with site visits or virtual site visits using electronic medical records. And these site visits are designed to confirm the completeness and the accuracy of the data in the databases. And we know from these site visits that the quality of the data is good, with most audited fields having completeness and accuracy of over 98%. Another unique feature is our sophisticated levels of risk adjustment. So within each database, tremendous effort has been made to develop clinical risk adjustment models so that we can assess outcomes adjusted appropriately for the varying case mixes between hospitals. So far what we've discussed is we have a very large database that has audited data that's believable and that has appropriate clinical risk adjustment. I guess the next piece is, well, what can we do with those data to improve quality? And I think I'd like to cover two topics when I talk about quality improvement. One, our relationship with the National Quality Forum, and two, our use of the database as a platform for public reporting. The National Quality Forum is a national agency that reviews and endorses quality measures for all forms of medicine and surgery. And perhaps the most rigorous methodology for approving a quality measure is the methodology utilized by the National Quality Forum. The Society of Thoracic Surgeons has the most quality measures approved by NQF of any professional medical or surgical society that exists. And that's something I think all of STS should be quite proud of. We have 34 quality measures in the domains of adult cardiac surgery, general thoracic surgery, and congenital heart surgery that have been vetted, reviewed, and approved and endorsed by the National Quality Forum. And these measures are then available to be used by the federal government, by state governments, by regional healthcare authorities, and by insurance companies to assess the quality of cardiac and thoracic surgery. The other piece that we've begun since 2010 using the STS database for is to publicly report outcomes. So we've used the STS database first with adult cardiac surgery and now with congenital heart surgery as a platform for public reporting based on our firm belief that patients and their families have the right to know the outcomes of the surgical treatments that they're going to receive, and that it's our professional responsibility to be able to share this information with our patients and their families in a format that they can understand. So on both the STS website and on Consumers Report website, one can access information about cardiac and thoracic surgical outcomes using the STS database as a platform. And this is because we have very strong beliefs in transparency. I guess to summarize what I've tried to say is that the STS database is the largest database in the world for our profession. It's got verified, audited data. It's got risk-adjusted data, and it's a platform for quality improvement and for transparency.
And Jeff, I think the other thing to re-emphasize is the importance of National Quality Forum endorsement for our measures, which tells us that these measures meet the highest standard of quality measurement, and that is not true of the vast majority of measures out there that are being used in healthcare. So it's very, very important, as you pointed out. Well, Rich, measurement is one thing, but what we're ultimately interested in is using data to really drive improvements in quality. You've had tremendous experience in Michigan bringing together all the programs in the state around the database to drive best practice. Can you tell us about that experience?
Yeah, Dave, thank you. We were actually very fortunate. I think we looked at the gold standard, which was the Northern New England, Jerry O'Connor, Bill Nugent, many other people like that. And some of the programs in Michigan started looking at their books that we got from the Duke Clinical Research Institute. And this is the late 1990s, and we had a platform for discussion. We had a professional society that we would get together once a year, as they say in Michigan, up north, for a 3-day meeting, get to know each other, have a couple of guest speakers, and we started talking about our data and realized, could we look at a book together? In other words, at that point, I was at St. Joseph Mercy Hospital in Ann Arbor, but would we put our data together blinded with the university and with Beaumont and with Henry Ford and with the programs on the west side of the state? And people started talking about it, and we came up with some funding and did it once, just to see. And it really was kind of an experiment. And we were coded, encrypted, so no one knew who anyone was, and you'd get your envelope and you'd go through it. And you'd start to realize that the person you had dinner with last night, they had better results than you did. And it really was kind of almost an experiment that you let take its own energy. What happened over the next year or two or three is other programs said, well, let's put my data there too. And we used this Michigan Society of Thoracic and Cardiovascular Surgeons to start, if you will, a regional collaborative. Virginia already had one, the Northern New England had one, so we were in our infancy, and this was 2001. And so we did this for 3, 4, 5 years, and we were fortunate in the state of Michigan, the major payer, Blue Cross Blue Shield of Michigan, had helped fund a group of interventional cardiologists to look at their data, create a database first. They had to create the whole database, and then look at it and share results and see if they could get better, use less blood after catheterizations, less acute kidney injury. So they kept coming to the Cardiac Surgical Professional Society and say, we'd like to fund you. Truthfully, we didn't accept the money for about 3 years. We just said, no, we think you'll want our results, we'll have to share them. Oh my gosh, we're paranoid, we're more paranoid now, we won't do it. What happened is eventually, and it was about 2006, 2007, enough people said, let's copy what the cardiologists are doing and do the same thing. What has evolved is we have the state of Michigan. There are now 33 programs in the state. They all play voluntarily. And actually, we had all the programs playing voluntarily before we had funding, because people saw value. Frankly, I hate to admit it, that I'm not sure every program looks at their own book or now their PDF of data. But when you get together, and then we started having quarterly meetings, people wait and see see a secret code on a screen, and they realize it's their hospital. It's easier to look at. So I'd like to, I think Michigan is like a super user. What we did was put it all together, have enough people in the room that got to know each other, and then about 7 years ago, we didn't encrypt it anymore because it took too long to keep looking up the codes. It was impractical. So we put all 33 hospitals' names up there so everybody saw everybody's results. Nobody became enemies. Nothing else changed. And frankly, if you look on our website of the Michigan Society of Thoracic and Cardiovascular Surgeons, all programs put their composites on our website. So we've come a long way. And I'm not sure I can give you the 5 steps that got us there. The funding, and we continue to get funding from Blue Cross Blue Shield, which is magnificent. And I would say if other insurers would do this, more people could do this. You need real funding. You actually do. You have to pay for meetings, the data, the analysis. So you need funding. It has given us a higher level of responsibility that we have to improve. So we've improved prolonged ventilation, internal mammary artery use. We've cut blood use probably 100% for most of our cases, dropped it. And it's not zero, but we've cut it way, way down in most sites in the state. So we pick things and share. What we do is we share. How did you do this? Well, I do this now. Well, I didn't think of that. And so it's a very cooperative, collegial environment.
Rich, has it been important to have a source of data that everybody trusted and that is adjusted for differences in case mix, and to have quality metrics that people believe in?
Yeah, I don't think it would have worked if we didn't have audited STS with the imprimatur on it data. I just don't think it, because people would argue, wait, my patients are worse than yours. We know the patients have to be worse in my hospital than your hospital. I mean, we've heard every excuse. But when it's these type of data from the best clinical database that exists, it's not, then you really start talking about how to get better.
Well, that's a great story from Michigan, and there are a number of other states that are now trying to emulate that, and it's something that we'd like to emulate really nationally. So it's a wonderful thing that you've done. You know, Rich and I are adult heart surgeons. Jeff is a congenital heart surgeon. Benj, is there anything that's unique about the general thoracic experience? I think it's a little bit different in some important respects than either congenital or adult, not only in the penetrance nationally, but who does general thoracic surgery, and and how you should be compared, really. Tell us about that.
That's a great question. You know, thoracic surgery as a true specialty is relatively new in the U.S. In Canada and abroad, it's been around for 20, 30 years at least. But in the U.S., it's probably the last 10 to 20 years where you have dedicated general thoracic surgeons. And so if you look at the age of the thoracic database, it started in 2002. We're now up to 271 participants. But that's way behind what happens in adult cardiac surgery. And also, if you look at who still performs thoracic surgery, particularly if we're talking about lung and esophageal cancer resections, there's a broad group of surgery specialties that are doing this. There are cardiothoracic surgeons and practices, both academic and clinical, who do both cardiac and thoracic surgery. And I think fewer of those surgeons participate in the thoracic STS database. Also, particularly on the esophageal side, you have a lot of general surgeons doing esophageal work. That's actually increasing, you know, with the development of kind of surgical oncology in those fields. And so we capture around 50% of the lung and esophageal cancer resections. That kind of fluxes from year to year. But it's not the penetrance of the adult cardiac and congenital databases. So, you know, we're fortunate to benefit from all the things that we've already talked about. We have the same risk-adjusted data. But if you look at the participants in the STS database and our outcomes for lobectomy, for example, they are fantastic. The 30-day outcomes for lobectomy have a risk of death of 1.4%, a major complication risk of 9%. That is not applicable to everyone doing lung and esophageal cancer surgery in the country. It's very different. So as we talk about public reporting, we agree that it's imperative that we use our data and the amazing platform that you and the STS have developed, but we have to figure out how to do it responsibly because you're looking at a select group that outperforms the national benchmark. And we've actually done that study as well. We've used the national inpatient sample. It's the best database that we think we can use for the comparison, that it's broadly generalizable to all of the operations performed in the US. And we outperform that database for both lung and esophageal cancer resection. So as we look to public reporting, we're going to compare participants against everyone else in the STS, but also against the NIS, against kind of everyone performing these surgeries in the country.
So is it reasonable to say then that, for example, a program that may be performing as expected in the general thoracic surgery database, that the as expected is based on a very select group of the highest quality surgeons, general thoracic surgeons in the nation. And that as expected group within the general thoracic community would probably well outperform the overall population of surgeons doing that kind of surgery in the country.
Absolutely, and that's the critical step. The beauty of the public reporting system is the ease of understanding it. 1, 2, 3 star. You can look at it and it's easy to understand. But the difficulty is that 2 star for the STS thoracic database means something different than it means in the adult cardiac database. And so I think we have to figure out how best to really begin this initiative for thoracic surgery.
Well, great. I'd like to thank all of you for giving us your thoughts about the database. I hope we've been able to convey the unique characteristics of the database, the fact that it provides data that are audited, that are clinically relevant, that are risk adjusted, and from those data we have a portfolio of some of the best quality measurements in all of healthcare. Furthermore, I think as Rich Prager has shown, these data can then be used to drive major initiatives in quality improvement because our goal is not to really just to measure, our goal is to improve. And finally, I think with the youngest of our databases, the results that are being generated by surgeons in the Society of Thoracic Surgeons who participate in the database are far superior to the general results across the country for similar types of surgery. Also want folks to realize that we are not resting on our laurels. We've come a long way over the past several decades, but we have many more exciting things planned for the future. Some of them will be implemented this year. For example, continuous data entry, real-time feedback, next-day feedback of results, progressive integration and interoperability of our database elements with other electronic sources, improved access of our participants to data in order to conduct research. Just a few of the things that we have planned in the years to come. So we just want to encourage everybody to be involved in the database, and I think you'll be as excited about it as we are. So thank you again.